self-medicating and high into addiction to substances.
So a history of self-medication and?
Addiction.
An addiction.
Into addiction.
Yes. Okay, so if somebody is, and what's the addiction to? What drugs?
Pot and meth.
Uh-huh, okay. So I think you're not going to get very far at all with psychiatric medications until the meth stops, because the meth is going to make it impossible to respond to mood stabilizers, atypical antipsychotics. So I would recommend a detox or chemical dependency program first before I even tried to treat the bipolar disorder. In the case of someone who's a chronic pot smoker, a little different. You might start with the same kind of psychotherapy and education and try to figure out what role is the pot playing. It may not be self-medicating. It's easy to say, okay, well, they have mania and depression, so they're smoking pot to get rid of it. It can also be that when they're manic or depressed, they do more of everything. They eat more food, they have more sex, they drink more alcohol, they smoke more cigarettes, they smoke more pot. And you may want to find out, is it sort of a habitual, sort of appetitive diet that the person is after, that they're trying to satisfy? What role does the pot play? What does it help them do that they can't do if they're not? And ask them to experiment with, what's it like a day without smoking pot? What do you feel? How's your sleep? How's your mood? Use themselves as their own experiment. I think there was two more.
Two questions,
one here? Yeah.
How does treatment look different for somebody that has rapid cycling?
Okay.
Because there is no delayed onset of, there's no prodromal features.
Right. So rapid cycling is an interesting phenomenon. For those of you not familiar with it, we define rapid cycling as people have 4 or more episodes in a single year. Although I think when people talk about rapid cycling, they're often talking about having episodes even daily or every once a week and so forth. First, we have to rule out thyroid abnormalities, because there has been in some patients a link with thyroid abnormalities and rapid cycling. Second, if there's an antidepressant in the picture, we usually stop it. If somebody starts rapid cycling and they're on an antidepressant, the antidepressant may be the culprit, not necessarily, but that's one of the things we would stop. Probably we would change medications. If the person's not doing well on lithium or Depakote, we might try lamotrigine or one of the other medications. If it's a chronic rapid cycling depression, we might treat that differently than a mania. The other thing we would tell the person is, in all likelihood, it will mellow with time, because rapid cycling is not a lifelong phenomenon. It tends to be for a couple of years when the person is restabilizing, and then they stabilize again.
And then there was one last
one more.
There was one right in here somewhere.
One more question? Or was there somebody in the back?
Okay,
One back here.
there we go.
In regards to heredity, does the family, the social aspect of like being in a family with a bipolar person, does that also, because a lot of times children grow up, their personalities are similar to their parents?
Yeah. Does living in a family where you have a bipolar parent, does that make someone bipolar, for example, by modeling their behavior? Not apparently. Only because there are a few of those twin studies where people are raised apart and they still have high concordance rates between identical twins, even though they weren't raised in the same family. I don't doubt that being raised with a bipolar parent can be very difficult, but it really depends upon whether the person's stable or not. If the person is stable, then I think the person can have a fine childhood. If they're constantly in and out of episodes in hospitals, of course that's going to be traumatic and anxiety-provoking for the child. But will it make them manic? Probably not. Not if they don't have the biological vulnerability.
I'd like to ask one last question, if I could. From your perspective as a researcher and your knowledge of other researchers around the world working on this problem, do you have some thoughts about the future and what hope we might have for people that suffer, for their families, on what kind of breakthroughs we might see as we look toward the future?
Okay, that's a good question. I think all of us are holding our breath to see what the healthcare system is going to offer us and how that's going to play out in mental health in general. In terms of research, I think it's probably going to be the case that we're going to start identifying the genes that are consistently related to bipolar disorder. What we do then is not entirely clear to me, because I know that often in genetics research, I don't know if you have the same reaction, but the premise is if we get the gene, then we'll know the treatment. And I don't think that's necessarily true. There may be a long period of time between identifying the gene and finding an appropriate treatment. Right. New drugs are being tested all the time. New psychotherapies are being tested. And also, I would put a lot of hope on brain imaging studies that are really identifying where is emotion processed in the brain, what are the triggers for emotion processing, and at some point we may be able to know what triggers can be controlled and which can't. That's what I'd like to see. And also, finally, prevention studies. People who, can we identify the kids who are at risk and do an intervention that might prevent it from occurring in the first place. That would be my hope.
Well, thank you very much. It's nice to end with some ideas.
Thank you. Thank you very much.